Ladies and gentlemen, neuroangio.org is proud to present to you the second BANANAZ Bites. As you notice, banana is now BANANAZ. The banana in-person lecture for November 2020 is kaput, secondary to the virus. However, our online education is very much alive and breathing, and I hope that you will visit BANANAZ and join us for our weekly BANANAZ lectures. The topic of this presentation is right here. Yes, it does sound a little bit corny, however, you will see for yourself. Here's a patient presenting with a typical subarachnoid hemorrhage. A CTA demonstrates what appears to be a rather small anterior communicating artery aneurysm. The angiogram is right here, frontal and lateral views. Maybe a little bit something suspicious there, but not exactly sure. So we do our 3D views. So here's a rotational angiography, volume rendered image. Now you start to see something resembling an aneurysm. We do a little bit more views, a few reconstructions, and now you see something that's a little bit more interesting now. We see a small aneurysm delineated by the solid white arrow, and around it we see what looks like a fenestration of the anterior communicating artery complex. Not an uncommon situation. Now this fenestration is associated with a dominant right A1 segment. The left A1 segment is atretic, and so we have a fenestration, both limbs of which are supplying the left A2. And in between the fenestration, along the vector of the flow, as is typically the case, we see a very small aneurysm measuring about 0.7 by 1.5 millimeters, based on both 3D and digital subtraction measurements. We have several views. The views on the bottom are from the bottom, unrealistic kind of a view, at least from the angiographic and the operative perspective. But that allows us to really optimally see this aneurysm. In fact, when we look at this picture, you can even further appreciate that there are two components to this, right? That's the typical appearance of a ruptured aneurysm. Very commonly you see this kind of a what we might call as aneurysm proper, pointed by the arrow, the white arrow. And then there's a little secondary pseudoaneurysmal component, most likely, and that's the arrowhead. That's the point of rupture. And altogether, this thing measures about, again, like 0.7 by something like 1.5 millimeters. Very, very small, right? So it's a small ACOM within a fenestration. And that's something that really is, first of all, obviously is unusual, but it's also remarkable. The degree to which we can appreciate all of this anatomy with modern technology. This is the latest, or, well, not the latest. Now there's another later version of, in this case, the Siemens technology that we're using here, and that allows us to really appreciate this anatomy very, very well. Now, once we're armed with this, we go ahead and do some views, and so the views confirm. We don't trust the 3Ds too much, to be honest, so we want to confirm everything on our DSA runs, and so here we have an oblique view that shows something very much like an aneurysm pointing inferiorly. Couple of other views. This is a little bit of a weird, more cranial view, in fact, but done more to resolve the kind of aneurysm versus fenestration situation. So all the arrows are the same. The fenestration is the dashed arrows, and the solid arrow is the aneurysm. These are the coiling views. So we discussed this and and in the end, we decide to try to coil it. And so here's the working projection views. The frontal view is a little bit difficult, but it kind of shows us the delineation of the aneurysm in the middle of the two fenestration limbs. And the lateral view allows us to see the aneurysm projecting below the A1 segment, and so that becomes our de facto working view. Is in fact more useful in the lateral than in the frontal, though they're both complementary. And of course, it's a small ACOM that we're coiling, a very small ACOM, in fact, and There are some difficult projectional issues that took some time to work out, but that's really where we are. And so what we do at this point is we have this, we float a balloon, we floated a little balloon into the A1 segment just to be able to inflate it should we encounter some extravasation. And what really worked out was this 45-degree angled SL10 that kind of was aneurysm seeking, so to speak, and so that kind of drops rather effortlessly into this aneurysm. You can see how we're hanging sort of towards the proximal aspect of the aneurysm. We don't want to put the catheter obviously too deep into it because that's where we want the coil to be. We don't want the coil to only have to go one way, which is out of the aneurysm, and so we keep the catheter at the base of the aneurysm neck to allow the coils the possibility to expand into the aneurysm. That's very critical, especially when the aneurysm is this tiny. So here's the coil. This is a 1x2 helical nano. We put in a 1x1, but realized it's a little bit too small, and so the 1x2 fit rather well. At this point, that's what we got. Now, we weren't gonna take too many chances with this, so what we did is a 3D with the coil in place, and you can see the coil is not detached. We still have, you can still see the all the wiring running through it, so the coil is still attached, and we just want to make sure it's sitting right, which it looks to be sitting just fine. Now at this point, we detach it, we do some working projection runs, which look exactly like this. And that's the post. So after that, belt and suspenders, we do another final 3D rotational. And so here's a volume rendered image of the coil in place. And this is the final frontal projection view. There's a native on the right and then the DSA on the left. So what did we show? Well, for once, I think we really, in all of these things and all of our pipeline experience and so on and so forth, and the web and these different things coming around, I think what's a little bit underappreciated is the advances, very slow advances in maturation of coil technology. All of these things, the imaging that we have here that allows us to really appreciate and understand what this aneurysm is, and the coils. The reality is that the challenging aneurysms are these. The tiny ones are the ones that are hard. And I think it's very important to see that the technology exists for us now to make this kind of embolization not only achievable, but I think reasonably safe. And again, this is, we've had these discussions. We have some excellent surgeons on all sides, and so there's more than one way to skin this cat. But I think an endovascular way ultimately is the way that the world is going. So if you can skin it this way, that's what you're gonna do. So that's it for this case. Now, some of you might wonder, did we show you a lot of anatomy? There's not too crazy of an anatomy here. So here you see like a short M1 segment with the lenticular striates coming from the proximal M2. But if you're hungry for more anatomy, which is what Banana Bites is supposed to be about, we're going to show you, just to satisfy your hunger, this venous phase of the same patient. So the venous phase shows a couple of variations worthy of note, one of which is what's called the posterior opening of the septal vein. The septal vein is this vein marked by the solid white arrows, right? That's the vein that runs in the septum pellucidum, and typically, classically would join the thalamostriate vein, which is kind of like these white dashed arrows. Where the black arrowhead is supposed to be the foramen of Monroe. And so the false venous angle is when that doesn't happen. So there's still a venous angle here, which is marked by that black arrowhead, but the septal vein opens posteriorly into the internal cerebral vein. In fact, its opening corresponds to another confluence with another vein called the medial atrial vein, which is that solid black arrow. And that's a vein that you will see also in the next picture. So here actually now we see the septal vein, right? So the white arrows, same white arrows, septal vein into the internal cerebral vein here. And now over here, the black arrows, same color arrows. So that's the medial atrial vein. So that's the vein running in the back and the medial aspect of the atrium that's collecting all of that white matter that's running around over there on the subependymal surface. So it's a tributary, a relatively consistent tributary of the internal cerebral vein. And finally, last but not least, we have a variant of the basal vein in the same patient. Yet again, we have the basal vein, so the mid-segment of the basal vein marked by the solid black arrows opening into a tentorial sinus, which is basically a dural channel in the tentorium cerebelli. So instead of running into the galen, which they most often do, they don't have to do that. The basal veins sometimes do something else. And so here's a tentorial channel marked by the dashed arrows. You can see the washout and the flattened, it's not a washout, it's a flattened kind of like appearance of this segment because it's running in the dura of the tentorium cerebelli, joining kind of the proximal aspect of the straight sinus. And with that, we've given you the anatomy and a little bit of intervention. And we thank you very much. Here's the CT of the same. That's a CTA. This is a CTA this patient got. As most CTAs go, it's venously contaminated, and so you can allows you to appreciate some of this venous anatomy that we've just shown. And so we thank you for your attention, and we encourage you all to visit neuroangio.org/bananas for all kinds of information related to our online BANANAZ